Susan.
Thanks very much for the introduction, and thanks for everybody for coming today. So as Noosh said, I'm going to first talk a bit about why we need to measure the health of a population as a whole, as opposed to measuring the health of an individual. Then I'm going to go through some summary measures of mortality and population structure and what they can and can't tell us about population health. Then I'll talk a bit about quality adjusted life years, or QALYs, and disability adjusted life years, or DALYs, which are two metrics which are commonly used by effective altruists and policymakers in trying to assess policies and find the most efficient use of health spending. Finally, I'll touch briefly on a more sort of philosophical issue about public health. So what should we be trying to measure here? Okay, so there are a number of reasons why policymakers and effective altruists are interested in population health measures. So they help policymakers get a sense of the main needs of a population as a whole. They can help prioritise these needs, to work out how to allocate the health budget when not everyone's needs can be met. So all societies have to deal with scarcity. This is a problem in all areas of life, but especially in the case of healthcare. Even wealthy countries can't afford to pay for all the preventative and medical care that would be beneficial to people. The problem's only going to get worse as the average age of the population gets older, and older people tend to need more medical care. Also, the cost of medical technologies has been rising faster than inflation for decades, and this seems unlikely to stop anytime soon. One straightforward place to start when you're measuring population health is just to start measuring the number of deaths in a specific population for a period of time like a year. One reason you might want to measure deaths is that because it's a relatively unambiguous metric. Death tends to be defined the same way across societies and across time periods. Many societies, even the ones that don't keep extensive records in general, often keep track of deaths and when they occurred. However, there's some obvious problems with analysis at this level. Simply tallying the number of deaths that occurred each year doesn't allow us to make important comparisons. For example, we can't use this metric to make comparisons across time. This is because population size changes significantly over time. Australia has about 158,000 deaths a year now, as opposed to 100,000 deaths per year in 1960. This rise doesn't mean that the health of Australians as a whole has got worse, as over this time period from 1960 to now, the population of Australia has also risen from 10 million to 24 million. Simply counting the number of deaths also doesn't allow us to compare between countries. Australia has 24 million people now, but the US has 325 million people, so it makes sense that the US has more deaths per year than Australia. Another important piece of information this doesn't provide is the age at which these deaths occurred. It matters a lot for health policy if the deaths are of babies or the deaths are of 75-year-olds. A simple adjustment you can make here is to not just count the number of deaths, but to express as a rate, which is usually expressed per 1,000 people. This is called a crude death rate, and it avoids some of these problems of comparing a growing country over time or comparing countries of different sizes. So agencies like the ABS, that's the Australian Bureau of Statistics, or the World Health Organization do actually publish crude death rates. However, there are some less obvious but still important problems with this, with the interpretation of crude death rates. For example, I've got up here on the slides the crude death rates of Norway and Uzbekistan here. So you might find it surprising that Norway has a higher crude death rate than Uzbekistan. Norway is one of the wealthiest countries in the world. I've got the GDP per capita here. It's much higher than Australia's. Whereas Uzbekistan has a fraction of Norway's GDP per capita. And generally we know that GDP per capita does have a significant effect on health. Okay, the reason why you might have this surprising result is that Norway and Uzbekistan have very different age structures. So the median age of a population is the age at which half the population is younger and half the population is older. On this slide, you can see that Norway has a significantly higher median age. And this matters because the probability that somebody will die in a year gets a lot higher as they get older. So a way around this age structure problem is to calculate what are called age-specific death rates. This is calculating a death rate for each age group separately. For example, calculating the death rate of 10 to 14-year-olds or 75 to 79-year-olds per 1,000 people in that age group who are in your population. This controls for some of the age confounders and it enables policymakers to focus on specific problems of the age group. But it doesn't give a sense of how the population as a whole is going. One solution you could use here is what's called an age-standardised death rate. So an age-standardised death rate is a summary measure that can be used to compare countries with very different age structures, such as Norway and Uzbekistan. This is calculated by first getting the age-specific death rates and then applying them to what's called a standard population. And one common standard population is the world population structure as a whole. And comparing them to a standard population means that then these different countries are now have the same age structure and their death rates can be compared. So when you look at the age-standardised death rates here of Norway and Uzbekistan, now you'll see that they've changed places, and now you'll see that Uzbekistan has a higher death rate than Norway. So another summary measure that's commonly used for population health is life expectancy. So life expectancy can be calculated at any age. So you can have life expectancy at 40, life expectancy at 60, but the most commonly used measure is life expectancy at birth. So life expectancy at birth represents the average number of years that a newborn baby would expect to live, assuming that they experience current age-specific death rates throughout their lifetime. So this is a useful measure, but it's often misunderstood, and it has more limitations than people often realise. So crucially, it doesn't predict anything. It doesn't predict that an average baby born in Australia in 2018 will live for 80 years or 84 years. It's likely that medical care, the social determinants of health, and environmental conditions will change a lot over the next 80 years. So there's no reason why the age-specific death rates that are the case now will continue to hold throughout that baby's lifetime. An interesting factor to note about life expectancy is that women consistently have higher life expectancies than men do worldwide. And as you can see, it's the difference of about 4 years in Australia and about 4 years worldwide. And this is the case even in countries that have very high levels of gender discrimination and violence towards women. Women still have higher life expectancy. So that's just a pattern to be aware of. So another measure that can tell us about population health is looking at the structure of the population in the form of a population pyramid and seeing how it can measure, represent patterns of fertility and mortality. So a population pyramid is a graph which shows us how many people or what proportion of the population fall into each age group. So males are represented on the left and females on the right. And I've taken this one from the ABS. So the vertical axis is for age, usually ranging from age 100 on the top to 0 at the bottom. And you can see that it tapers off at the top. That's because there aren't very many 100-year-olds. And then the horizontal axis tells you either the proportion of the population or the number of the population who are at each age. So on this graph, you can see that there are about 150,000 males at age 0 in Australia in, I think this is 2017. Okay, population structures, together with background information, can also tell us about events that happened in the past and affected population structure. So, for example, here's a population pyramid of mainland China with the data from the Chinese census of 1990. Okay, and I've made this graph kind of very conventional, so pink is for women and blue is for men. If you look at this pyramid, and the circle around the pyramid, you'll see that there are very few people aged around 30 years old on this population pyramid. Remembering this is from the 1990 Chinese census, the people in the gap aged about 30 here would have been born around 1960. At this time, China was experiencing an enormous program of industrialisation, which led to the deaths of about 30 million people from famine. You can see some of the effects of the famine deaths as well further up the pyramid. But one very large effect of this very large famine was that fewer women became pregnant and a greater proportion of babies and small children died around 1960. And you can see this represented on the population pyramid. One of the main ways that people outside China found out about the scale of this famine was through looking at demographic data like this when it became available to them in the 1980s and 1990s. Okay, so these mortality and demographic metrics can be very useful, but they're also limited. What if when we're interested in the health of the population, we're not just interested in how long people live for. We're also interested in what states they live these years in. Are they living these years in perfect health, or are they dealing with chronic illness? One solution to these kind of problems is to produce a metric that includes both the number of years lived as well as the state of health that these years are lived in a single metric. So the two best known metrics of this kind are quality adjusted life years, or QALYs, and disability adjusted life years, or DALYs. So both QALYs and DALYs measure a number of years by the quality of those years. So they can be thought of as complementary concepts. QALYs are years of healthy life lived, and DALYs are years of healthy life lost. So one QALY represents a year lived by one person in perfect health, and 0 QALYs represents that year wasn't lived at all. So there's the range is from 0 to 1. And then you can add them up for the different people or more than 1 year. So in general, health policy would aim for fewer DALYs and more QALYs. DALYs and QALYs aim to incorporate many effects of healthcare in a single measure in a way that enables easy comparisons between individuals and populations. So how can we assess the quality or utility of living in a particular state of health? So there are a number of techniques, and they ask participants in a study to choose between certain probabilities or lengths of time having a particular health condition compared to an amount of time spent in perfect health. To take a really simplified example, suppose that participants in a study are indifferent between 7 years of perfect health and 10 years of being deaf. So then the condition of deafness would have the utility of 0.7 for a QALY and the converse for a DALY. QALYs are most commonly used in making national health policy, whereas DALYs are more often used by the World Health Organization or research and development agencies. However, in my view at least, the strength of QALY and DALY metrics is also their weakness. So the construction of DALY and QALY metrics tends to conflate two ethical questions that I think should be considered separately. One of these questions is how to evaluate an intervention that assists the quality of life of someone. The other question is how to evaluate an intervention that extends the life of somebody. So other problems with the use of DALY and QALY metrics is that they can also discriminate unfairly against people with permanent disabilities, as the measure puts an upper bound on the benefit that people with permanent disabilities can receive from health interventions. According to these metrics, a permanently blind or deaf person can't be counted as being in perfect health. So a QALY counts an extra year of life as being less valuable to them than the same extra year of life for someone with no disabilities. So it might be desirable for policymakers to have a single metric to compare all health interventions. However, by forcing ethically separate issues into the same measure, these health metrics come at the cost of making counterintuitive measures of health that don't accurately represent people's beliefs or social preferences. So in this talk, I've discussed what we do measure when we try and evaluate the health of a population. However, there's another issue. What should we be trying to measure? It's relatively uncontroversial that a person's health status affects their quality of life and their well-being. One question about health measurement and priorities in the philosophical literature is to what extent we should be trying to measure only external observable factors, such as how well people can see, how well they can move around, or how well they can function in everyday life. Or should we also try and measure less external factors, such as how people subjectively feel about their quality of life? So one major reason, so I'm going to mention one reason for and one reason against, including these subjective measures. One reason for measuring and focusing on external criteria almost exclusively is that this avoids many of the intuitive problems with adaptive preferences. So an adaptive preference is a preference that's not what people actually prefer, but it's just a psychological adjustment to help them cope with a suboptimal situation. So many philosophers think that in the case of adaptive preferences, as the people involved would want something different if that was a realistic possibility, their current preferences and their current expressed subjective well-being shouldn't be taken as an indicator of how badly off they are, and it shouldn't be taken as a guide to resource distribution. And so, in this view, adaptive preferences confuse the issue and make it difficult to use subjective well-being to come up with priorities in healthcare. However, one reason to include subjective measurements is that it can be contentious which objective measurements actually matter for people's real well-being and quality of life. For example, some health issues like chronic pain can be largely invisible and are often overlooked by traditional measures of functioning. So many people in chronic pain are able to work full-time, they have hobbies, they care for their families and so on. But they have very poor subjective well-being. Other health issues might be more visible, but not actually cause as much suffering or distress. So measuring subjective well-being as well as objective well-being can provide a corrective to more external measures that might otherwise be overlooked or overemphasised. And I'll leave it there. Thank you very much.
Thank you so much, Susan, for that talk. This is something I am personally fairly interested in. And I've just closed my questions, which was silly. Well, one question which I saw got highly voted, which I'm pleased to say I asked myself.
That's always good.
Yes. Are there any estimates or work into an average QALY span? So if an average lifespan is 80 years, how many quality adjusted years can we expect to get?
There has been work on that, but that really depends on how you calculate a QALY and what system you use for calculating well-being or utility. There are a number of what are called multi-attribute indices made by different organisations, such as different universities, which measure sort of quality of life. And so, sorry, this is not a very useful answer, but it would really depend on whose methodology you use. But yes, there are definitely things out there which can tell you that.
Great. So it seems to me that the impact of living with a disability depends hugely on the environment you are. So, for example, if you're in a wheelchair, how many ramps are there in your city?
Yeah.
Does that mean that DALY estimates have to vary by location?
So that's a great question. One of the criticisms of DALY measures and QALY measures is that they don't vary by location. So being blind in Australia is going to be subjectively a very different experience due to environmental differences than being blind in Niger, which is a very poor country. But most of the QALY measures at least DALY measures will count it as the same. And so that's definitely been a criticism of it. There are some QALY measures which are designed to be specifically limited to a particular country or a particular group of countries. However, I think in practice, largely health economists, especially Australian health economists, tend to just take these quality of life measures or utility measures from other countries and just apply them in Australia. So there's a health-related quality of life index which was created in Canada, and Australia just kind of uses it. There are differences between Canada and Australia. It's a problem it's definitely a problem, and it's something that could be ameliorated a bit, I think.
So something you alluded to is that if you ask somebody with a particular condition to rate their own quality of life, and you also ask people without that condition to imagine what that would be like, you get very different values.
Yep.
Would you like to comment on that and how you think we can resolve, what is the truth?
So this is kind of a contentious philosophical question, because sometimes people say that we should only ask people who don't have the condition, because the people who do have the condition have sort of adapted and they've got used to it, and they don't have a very good comparison point because they sort of got used to their own condition. And some people say that you should, and so that's the problem of adaptive preferences. And some people also say that when you're doing QALY and DALY metrics, because they're often used for setting priorities in a national healthcare system, then what you should be aiming to reflect is the priority. So if you're trying to do priorities within the Australian healthcare system, what you should be trying to do is accurately reflect the priorities and preferences of the Australian people as a whole. So that's what some people think you should do. Other people say, look, people who don't have the particular condition are just going to be wrong about it, and their preferences are going to reflect ignorance and sometimes prejudice, and they're just not very useful. So that's a reason from the other side. I guess what I personally think is that you should use both. So you should use both the subjective well-being and the preferences of people who have that particular condition, but you should also look at how well they can function and some of the preferences of society as a whole to adjust for adaptive preference issue, and hopefully the strengths and weaknesses, the weaknesses of each method can be made up for a bit if you use both.
So would that be you would take some kind of average of the two, assuming one is reliably higher than the other?
I think that you should weight the metric of objective functioning. So a functioning metric being something like how well people can fulfill external criteria like see or hear or move around or function everyday life. I think you should weight that somewhat with the subjective data. And so that might mean that conditions like chronic pain get bumped up the priority list a bit because they have people with chronic pain have very poor subjective well-being. And some conditions are going to get bumped down a little bit. So especially conditions which might be very visible but actually don't cause, so some very visible disabilities that don't cause a lot of suffering and distress. So I think that they should both be used, but not to the exclusion of each other.
Susan, thank you for sharing your expertise with us.
Thank you very much.